Hello, this is John Kanalopoulos presenting on behalf of Georges Melis. This work comes from our institute in Athens, the LaserVision.gr Clinical Research Institute, and entails a laboratory ex-vivo study in human corneas of comparing small-incision lenticule extraction, the SMILE procedure, to LASIK. We try to compare their biomechanical behavior in two different setups. Dr. Melis has no financial disclosures on this study. I consult for Alcon, Avidro, Allergan, iOptics, OptiView, Curamed, Zeiss, and IPS Surgical. The removal of cornea tissue by the procedure inevitably leads to reduction of corneal biomechanical strength. Concomitant contributing factors also exist attributed to the nature of each procedure. In SMILE, for example, there is less significantly anterior cornea subjected to transverse separation. Only 50 degrees of the anterior cornea is incised. This is usually 140 microns in the typical SMILE procedure today. In addition to the limited anterior stromal severance, the tissue is removed from deeper stromal layers than in LASIK, and that has been reportedly less biomechanically significant. In LASIK now, the flap, usually between 100 to 120 microns thick, is transversely separated more, almost 300 degrees, except of the hinge. The perpendicular side cuts sever the anterior stromal lamellae, which contribute more to the biomechanical strength of the cornea. We attempted to evaluate these effects, tried to standardize the biomechanical evaluation between the two procedures ex vivo as a result of low, -3, and high, -8 myopic correction performed with small incision lenticle extraction, SMILE, employing the Biomechanics laser by Carl Zeiss Meditate, Jena, Germany, compared to femtosecond LASIK performed with the refractive suite, the FS200 and EX500 lasers by Wavelight, owned by Alcon Surgical, Fort Worth, Texas. Methods, and this is quite an elaborative study. We obtained 30 human donor corneas from the eye bank for site restoration in New York City for this experiment, and we subjected them to myopic SMILE or LASIK. The corneas were randomly allocated into 4 groups, 5 corneas in each group that received the following treatments. Group A received a -3 diopter treatment of SMILE. Group B, a -8 diopter treatment with SMILE. Group C, a -3 diopter treatment with LASIK. And Group D, a -8 diopter treatment with LASIK. Additionally, 2 groups were formed, one for each procedure. Group E, SMILE, and Group F, LASIK. The corneas in these control groups were subjected to the corresponding femtosecond laser lamellar cuts, but not to tissue removal. The biomechanical evaluation of tensile strength was conducted by biaxial force application. Primary outcome measures were stress at 10 degrees and 15 degrees strain, and Young modulus at 10% and 50% strain. It is estimated that both procedures result in reduction of biomechanical strength. The larger the myopic corrected, the more reduction. Relative differences between the two procedures are unknown, as they have never been previously investigated ex vivo or in vivo. So in the results in SMILE, the average relative difference, delta, of the 4 metrics evaluated, as we mentioned before, was a -35.6% for the -3 diopter correction versus the control, and -50.2% between the -8 diopter correction and the control. So we're seeing here a almost 1/3 reduction of the biomechanic performance with the method studied between the -3 myopia correction with SMILE and the control, and almost half between the -8 correction and the control. Now in LASIK, the numbers were a little bit milder for the -3 diopter correction, and we'll talk a little bit about that, why that probably is, a -21.2% between the -3 correction control and A very similar number with a small group, a minus 50.4% between the minus 8 correction and control. So in summary of the results, when comparing same myopic correction, SMILE compared to LASIK, it appears to result in a more biomechanical reduction for the minus 3 corrections by 25.9%. So SMILE appears to be worse as far as preserving biomechanics for the minus 3 myopes, while the two procedures appear to be almost head-to-head for the minus 8 diopter correction, again with the methodology used with this study. These data come to a surprise even for us, and in discussion, the potential advantages of SMILE over LASIK, other than the biomechanical aspect, include reduced dependence on environmental factors that may influence excimer stromal ablation, such as laser fluence variability, stromal hydration, reduced possibility for operating room airborne foreign body interface contamination, and potentially reduced postoperative dry eye symptoms. In terms of cornea sensation and dry eye outcomes, some studies have shown equivalence, if not superiority, of SMILE over LASIK, and this really does make sense since SMILE is the less invasive of the two procedures as far as the cornea surface and the anterior corneal lamellae. The prime aspect involved in this study is the investigation of the inevitable reduction of corneal biomechanical strength as a result of either procedure. It's important derives from the fact that significant loss of cornea strength in large myopic corrections may lead to refractive regression at best, and or the possibility of the ominous iatrogenic ectasia, meaning iatrogenic keratoconus. In LASIK, in addition to the ablated tissue, the flap further contributes to reduction of cornea strength despite being attached to the treated stroma, as it may not contribute significantly to the biomechanical strength of the underlying stroma. In SMILE, in principle, the cornea should be less affected compared to any given LASIK or PRK procedure, as most of the anterior stromal lamellae remain intact above the cavity, quote-unquote, created by the extracted lenticule. Factors in support of this are the depth dependence of transverse shear modulus of the cornea, stronger of the anterior third, meaning the cornea has been studied and is stronger in its anterior third segment, which is less involved in SMILE. These effects have been modeled in computer-generated models, but to the best of our knowledge, never there has been a similar experiment, either ex-vivo or in vivo, looking at these findings. In this study, we conducted a human ex-vivo comparative investigation of the potential in-plane tensile strength reduction in cornea subjected to SMILE and femtosecond laser-assisted LASIK, and this is the first such experimental investigation of this issue. As mentioned before, these findings do generate more questions than actually answer. The evaluation of the tensile strength we employed by axial stress strain measurements, which may be considered superior to previously employed cornea strip extensiometry, is a definite advantage in our opinion. In addition, the orientation of the cornea specimens during the tensile measurements was intentionally random, exactly to address the fact that the in-plane biomechanical properties may naturally vary along different meridians of the cornea because of the known anisotropic differences of cornea collagen, as has been reported. The data in the study suggests that SMILE LASIK appear to result in statistically similar tensile strength reduction for higher myopic corrections, -8 diopters, where we have to note biomechanical issues are of more importance. However, to our surprise, LASIK appears to result in less cornea strength reduction in smaller myopic correction, the -3 we chose in this study. Now, why that is, we theorize that results may be attributed to the number of significant differences between the two procedures. SMILE results in more tissue removal with its current form due to a priori minimal 15 microns of tissue that has to be removed with even 1 diopter on top of 1 diopter tissue corrected. So for a -3 diopter smile correction, the maximal lenticle thickness in its center was 64 microns. For the -8 diopter smile correction, the maximal lenticle thickness to be removed as a design was 136 microns. Now these are under 140 microns, which is the typical quote-unquote untouched cornea, anterior cornea by the procedure. In LASIK, the relevant numbers are for -3 corrections 45.51 microns, and this is under 110 microns, not 140, and for 8 diopter corrections 114.71 microns. So these differences exist despite the same optical zone for the procedures noted here. So the data correspond with an average 19.5 microns per diopter of removed tissue with smile compared to an average of 14.74 microns per diopter of ablated tissue for LASIK. Now, some limitations of this study in closing is that we included limited statistical power due to the small sample size and the assumption that the in-plane tensile strength testing along the XY axes of the tissue studied correspond with in vivo biomechanical behavior of the cornea. Now, this is a huge assumption, and of course it's a major limitation with the way the study was designed. Additional studies with differentiation of myopic correction applied and depth of lenticule may be warranted to validate further investigative findings. Also, evaluation of transverse shear biomechanical strength, meaning the power needed and the resistance if a force was pushing in the center of the cornea from inside out, may also contribute in higher value with this issue. Thanks very much.